probable signs, so your allotment, Chadwick's, Goodell's, Hagar's. Make sure you know the difference between Goodell's and Hagar's, because those are often confused. And then that positive pregnancy test. Like I said, I put it up there so you guys can look at it again. If you have questions, just stop. I don't even know what time it is, but I know you guys are staying after. So your positive signs: fetal heart tones, a practitioner feeling the movement, so Leopold's maneuver is feeling the outline, ultrasound, the fetal outline. So Nagel's rule, remember, however you like it, either subtract 3 months and add 7 days and adjust the year, or people like the other way too. So fundal height, used to determine duration of pregnancy in weeks. So second and third trimester, it should approximately equal the weeks of gestation. These ones we'll go over again. So a non-stress test, we put the monitors on because we want to see if fetal movement makes the heart rate accelerate. So interpretation, it's reactive if we have 2 or more fetal heart rate accelerations. So 15 by 15 within a 20-minute period means up 15 beats for at least 15 seconds. If it's before 32 weeks, it'll be 10 by 10 because it's not as reactive. And non-reactive, we do not have any qualifying accelerations in that 20 minutes. Contraction stress test, remember we put them on the monitor, we give them something to start contractions. Once we start contractions, we look to see if there's any late decelerations. So a negative contraction stress test is a normal, and there's no decelerations with the contractions. That's a reassuring finding. Positive, that's the abnormal one. So there's late decelerations occurring with 50% or more of the contractions. They don't like that finding. It's suggestive of your placental insufficiency. So make sure you know the difference between those two. Your biophysical profile, remember they look at a couple different things. They get a score of 0 to 2 per section. So fetal breathing movements, we want at least 1 episode of 30 seconds in a 30-minute period. Body movement, so at least 3 body or limb extensions with return deflection. Fetal tone, so gross movement or having it in, arms and legs in. A reactive fetal heart rate monitor test. And then looking at the amniotic fluid. We want at least 1 pocket of fluid measured 2 centimeters. So if they're 8 and above, that's a good sign. If they're below that, then they start to worry. Amniocentesis, performed 14 to 16 weeks gestation. It can also be performed in late pregnancy if we're looking at lung maturity and well-being. So an LS ratio of 2 to 1 indicates lung maturity. So remember, we need to put it on the fetal heart rate monitor, look for signs of labor, any bleeding, check their vital signs. If the mom is Rh negative, she needs to have a rhodium shot. And then educate to report bleeding, contraction, signs of infection. Chorionic villi sampling is 8 to 12 weeks where they go in and take a piece of like the placenta and sort of look at genetic. That can just be done earlier. Same risks, as amniocentesis. Classification of pregnancy. So Gravda, number of times pregnant, regardless of the duration, and includes a present pregnancy. Prima gravida, pregnant for the first time. Multa gravida, pregnant before. And then para is a number of pregnancies that lasted more than 20 weeks, regardless of outcome. So the GTPAL, everybody least favorite. Just divided out to G is the number of times pregnant, T is the term, P preterm, A abortions, and L for living children. So I'm not sure. Have you guys had that on the practice tests at all in NTI? Oh, okay. Hopefully they won't ask you that. So they might just hopefully say grab a para instead of. So complications of pregnancy, hyperemesis gravidarum, that's that persistent vomiting. We want to give them fluids and electrolytes, and then can do antiemetics. Vaginal bleeding can be indicated of placenta previa, so that's that placenta over the cervix and has painless vaginal bleeding. There's abruptio placenta, separation of the placenta before the third stage of labor, and it produces painful abdomen, usually bleeding, but never painful abdomen, or a threatened abortion. It can't have dark red, yeah. Yeah, placenta previa is usually more of a bright red. Abdominal pain, and you report that that can indicate threatened abortion, ectopic pregnancy, abruptio placenta, or placental abruption. They have 1,000 different names for all these things. Incompetent cervix can cause a spontaneous abortion. You can correct that with doing McDonald's cerclage. Protein, headaches, edema of the hands and face can be indicated preeclampsia. Premature rupture of membranes. Remember, anything over 24 hours, we're worried about infection. Excessive rapid uterine enlargement can indicate hydatiform mold. So that's usually either one egg, 2 sperm, or nothing in, no genetic material in the egg. Causes those Great Lake clusters. And then your types of abortion or miscarriages. Elective, evacuation of the fetus. Threatened, produces spotting, but the cervix isn't open. We haven't passed really anything yet. Inevitable, part of the fetus has passed. Incomplete, fetal demise, but nothing has passed. Complete, all parts of conception has passed. Septic is usually some kind of presence of infection. And missed, fetal demise, but no expulsion of the fetus, and usually due to induced labor. More complications, diabetes. Screening test needs to be done on all clients. They usually do it around 28 weeks gestation. So they usually do a 1-hour glucose tolerance test. So if it's greater than 140, then they'll have to do a 3-hour. And if 2 of the 3 are elevated, then it's gestational diabetes. Newborns tend to be large for gestational age due to glucose crossing the placenta. At birth, they're pudgy, red, lethargic, and they have low blood sugar. They get real shaky and jittery. Complications, if they're diabetic going into pregnancy, they can have congenital heart defects, and then all of them polyhydramnios, premature delivery, respiratory distress syndrome, hypoglycemia, macrosomia. See, it all comes back, doesn't it, when you...
Yes, it does.
Preeclampsia, the diagnosis criteria: elevated BP, facial edema, protein in the urine. Mild preeclampsia is treated with red breast, low sodium diet, and monitoring. Severe preeclampsia, BP is usually greater than 160 over 110. Protein in the urine is usually greater than 5 grams. They usually have oliguria, and then they can have, cerebral, visional disturbances, headaches, gastric pain, pulmonary edema. Remember, they can go into HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. So they need to deliver the fetus. If they have a seizure, then it's eclampsia. So management of severe preeclampsia, strict I's and O's, quiet, dark environment, seizure precautions. They'll put them on magnesium sulfate. Therapeutic level is usually 4.8 to 9.6. Common side effects are hot flashes and drowsiness. Complications, maternal hypotension, oliguria, can have apnea, loss of detected reflexes, decreased respirations. The magnesium level should be checked every 6 hours, and treatment for toxicity is calcium gluconate. Eclampsia is usually severe preeclampsia accompanied by seizure activity. So it can be preceded by headache, blurred vision, epigastric pain, altered mental status. Thing in here is to monitor the mom, make sure her airway tries to stay open, and monitor her afterwards. So DIC, bleeding disorders, when all the clotting factors are used up, and then widespread external, internal bleeding, diagnosed by the presence of fibrin split compound. So the treatment, they usually do heparin to treat the clotting, Amicar to stabilize the bleeding, electrolyte replacements, blood transfusions, and oxygen. Cord prolapse occurs when the umbilical cord is expelled with rupture of membranes, comes down before the presenting part. Pressure exerted on the cord causes fetal hypoxia. So we either need them in a Trendelenburg, knee to chest, or keeping the presenting part off of the cord. Need to give IV infusion, oxygen, prep for a C-section. If the cord is hanging out, sterile saline to prevent it from drying out. Rupture of placenta separating from the uterine wall, results in bleeding or like abdomen and pain. Treatment is delivery of the fetus, usually have hypotension. Like I said, previa is placenta, implants over the cervix, painless bleeding, usually have to deliver by cesarean section. Study all this, the torch infections. Remember that if there is any active genital herpes lesions, they have to have a C-section. Group B strep, cultures are 35 to 36 weeks, and this can be passed to the neonate during labor and delivery, and then cause respiratory problems. So we want to administer penicillin or ampicillin during labor. RH incompatibility, basically RH antigens from an RH positive fetus enters the bloodstream of an RH negative mom, where then she produces antibodies, so that she has another RH positive baby. Those antibodies destroy the fetal red blood cells. Does not affect the first pregnancy, but affects subsequent pregnancies. So we need to give Rogaine at 28 weeks, and then with 72 hours of a positive fetus. And anytime there's bleeding involved, if she's spotting, doing any kind of test where there can be bleeding, we need to get that. Preterm labor that occurs prior to 37 weeks. So medication to stop the contractions, or magnesium sulfate. Breathing or terbutaline, remember that has that black box warning, so we're not to take it longer than 48 to 72 hours. Can cause tachycardia, hyperglycemia, hypotension, and chest pain. Procardia, calcium channel blocker, can relax the uterus. It can also cause tachycardia, hypotension. And then indocin, which is an NSAID, suppresses labor by blocking prostaglandins. And then betamethasone, steroid that we can give to the mom to improve the LS ratio, so the lung surfactants. If preterm labor cannot be stopped, then we should start these. It's administered IM to the mom every 12 hours times 2. And then can be given weekly until 34 weeks gestation. Premature infant prone to rapid heat loss through conduction, convection, radiation, evaporation, so all the complications. I don't think they test too much on this, but respiratory distress syndrome, pneumothorax, necrotizing enterocolitis, bronchopulmonary dysplasia, and bleeding disorders, especially into the brain. So treatments are usually give mechanical ventilation, surfactant, usually through an ET tube. They can squirt it down and it'll help with their breathing. True labor versus false labor. False labor is usually the contractions are irregular, inefficient, and they do not cause progressive changes. There's usually no bloody show. Discomfort primarily in the abdomen and can be relieved by walking. Whereas true labor, contractions increase in frequency, intensity, and duration. They'll show progressive cervical changes. They usually have bloody show, progressive fetal descent. Walking intensifies the contractions, and discomfort begins in the back, radiates to the abdomen. Stages of labor. Stage 1 is closed cervix to 10 centimeters dilated. We have latent 0 to 3 centimeters, active 4 to 7, and transition 8 to 10. Stage 2 is complete cervical dilation to delivery of the baby. Stage 3 is delivery of the baby to delivery of the placenta, and then stage 4 is delivery of the placenta until complete recovery of the mom. The 6 P's. So our passageway, so that includes the pelvis. Gynecoid is the normal female pelvis. Inlet is rounded. That's what best for labor. Android is more male, should be male. Inlet is heart-shaped. Anthropod, inlet is oval, and platypod, flat female pelvis, just in case they ask about those things. Soft tissue distends and dilates, and the ability of the vaginal canal to distend for delivery. The passenger, so remember, hopefully the fetal head is presenting. Fetal attitude is the relationship of the parts to one another, so flexion or extension. And fetal lie is the relationship of basically the spine to the maternal spine, longitudinal or transverse. Presentation, cephalic is the head, breech, butt or feet, shoulder, usually seen in the transverse lie. Station of the presenting part in relationship to the maternal spines. 0 station is at the ischial spines, that's, and it goes from -5 to +5. So +5 is lower or getting ready for birth. Negative is up in the uterus. Position as a relationship of the presenting parts in the mother's pelvis. So LOA is left is a bit anterior, back of the baby's head is anterior to the pelvis, and tilted to the left side. Hopefully they don't ask much about this. Just remember that if the heart rate is above belly button, we're usually looking at a breech. And then powers are the contractions, duration of the contraction for time between the first tightening and its complete relaxation. Frequency is the beginning of one to the beginning of the next. And intensity is the firmness of the uterine muscle during the contraction. And then we have psyche and position. So the mother's psychological response to labor and her position, how she's, if she's out or laying flat. So oxytocin, it's smooth muscle stimulant, so it helps contract the uterine muscle, increases force, frequency, and duration. We can use it for everything from managing incomplete or inevitable abortions, getting them delivered, controlling postpartum hemorrhage, inducing labor, facilitating uterine contractions. Contraindications, previous uterine surgery, placenta previa, fetal distress, without immediate delivery. So our side effects: tachycardia, premature ventricular contractions, hypotension, and water intoxication. We have to watch how much fluid we give them when we're giving them Pitocin. And then monitor the frequency, duration, strength of contractions. Stop if contractions are lasting longer than a minute, occur more frequently than 2 minutes, and any alteration in fetal heart rate. Our fetal monitoring, so baseline normal is 110 to 160. Tachycardia is greater than 160, so maternal fever, maternal tachycardia, fetal neurologic immaturity are some examples of what causes it. Bradycardia is less than 110, so later signs of fetal hypoxia could be mom had a pain medication or fetal sleep, and it is known to occur before fetal death. Variability is the irregular fluctuations in the baseline of the fetal heart rate. So we like to see at least moderate, but absence, usually when it's straight line's a bad sign. Minimal could be with pain medication or sleep, and then marked is usually fine too. So that loss of variability, that smooth baseline, like I said, maternal medications, fetal acidosis, fetal neurologic immaturity. Our periodic changes, our accelerations, an increase in fetal heart rate above the baseline indicates fetal well-being. Early deceleration, I got all kinds of interesting things with these questions. So early decelerations, this is head compression. So remember your veal chop. So gradual decrease of fetal heart rate with return to baseline coincides with the contractions. So this we just maybe check, continue monitoring, maybe set up for delivery. Make decelerations. Gradual decrease in fetal heart rate below baseline late in the contraction and doesn't return until after the contraction is done. Uteroplacental insufficiency. So this is turn her on their side, increase IV fluid, oxygen, decrease or stop Pitocin. Variables is umbilical cord compression. So decrease in fetal heart rate with no relation to contractions. So with that, just turn her side to side, or we can use amnio infusion. Postpartum care, monitor vital signs, respiratory rate should return to normal after delivery. Temp may be elevated a little bit from dehydration and exertion. BTP usually returns to normal within 24 hours. Bundle check should be firm, not boggy. After delivery around the belly button, 1 centimeter above or at the belly button within 12 hours. And then it will start going down about 1 to 2 centimeters a day. No longer palpable about day 9. And the lochia is discharged. So rubra, bloody with small clot, spots, usually the first 2 to 3 days. Serosa, pink or brownish, about day 3 to day 9. And alba begins about day 10 and may last for several weeks after. Check perineum for lacerations or episiotomy, 1st to 4th degree. Nursing care, ice packs at the first 12 hours. Then warm sitz baths. Observe for signs of infection or hematoma. Start to climb out perineal hygiene, medications, Tylenol, Motrin, Kool-Aids to avoid straining. And then your APGAR scores at 1 and 5. For neonatal care, apical should be 120 to 160, respirations 30 to 60, blood pressure 60 to 40 to 90 to 45. Loss of body heat, evaporation, convection, conduction, radiation. Hypoglycemia in the newborn is 40 or less. And then our Ballard scale, which shows gestational age. And then I just put in some things here. Acrocyanosis, bluish discoloration on the hands and feet. Caput cephalum, edema that crosses the suture line. Cephalohematoma, blood that does not cross the suture line. Hyperbilirubinemia, elevation in infant's bilirubin caused by immature liver. So anything before 24 hours is usually a bad sign, usually means there's problems with ABO compatibility. Levels 12 or greater may require phototherapy. Kernicterus or delirium encephalopathy occurs at 25 and higher from brain damage. Lanugo, the